welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me, as always, is CMS MD CEO, Dr. Joshua Liu. Today, we're joined by our very special guest, Mr. Brent Kruschel. Brent is currently the Vice President of Digital Health at Interior Health in British Columbia, Canada, where he is responsible for digital health strategy and operations, clinical and business analytics, information management and technology services, and IH-wide implementation of advanced clinical information technology solutions. Brent joined Interior Health in 2002, holding various positions within the information management and technology portfolio, prior to taking a leadership role in capital planning project delivery in 2016. During his time at IH, Brent led several technology initiatives, including the regional implementation of Meditech and the launch of the My Health portal. As Chief Project Officer, Brent led the development of the David Camp Tower at Penticton Regional Hospital and led the planning and procurement of the Gaglardi Tower at Royal Inland Hospital. In 2019, he left IH to become the VP for Technology, Informatics, and Facilities at Fraser Health before rejoining Interior Health team earlier this year. Brent holds an MBA from Smith School of Business at Queen's University and the Bachelor of Commerce degree from the University of British Columbia. Brent, welcome to the show.
Well, thanks, Alan, and thanks, Joshua, for having me. It's great to be here.
Absolutely. Well, we're absolutely thrilled to have you on the show today. I feel remiss. Right now, British Columbia is currently on fire, and we had a bout of that in Ontario a few months ago. But how are you doing over there? What's going on?
Yeah, it's quite the scene here in the Okanagan Valley, which is where I'm based out of. 20 years ago, we had the anniversary of the Okanagan Mountain Park fires, where somewhere in the neighborhood of 300 to 400 homes were lost. And sure enough, right as we're commemorating that, fire breaks out in West Kelowna and has the audacity to jump the lake and start additional fires in the east side of the lake. So we're in an emergency management state right now. We're actively watching and receiving updates on the fire. We've actually had to evacuate 9 long-term care and assisted living facilities. Just under 900 residents we've had to relocate from their homes. Moving a long-term care resident, especially, in our dementia units or our cognitive behavioral units, it's not something you take lightly and it takes time. So we've had to be very proactive, working with a multitude of agencies to ensure those residents are able to stay safe.
Well, I hope everything goes well from here. I think it's finally caught some rain over in BC, I read this morning. So hopefully that turns things around. Well, Brent, it's fantastic having you on the show today. As you know, our show is focused on digital health, and you've had one of the most fantastic careers in healthcare that has really spanned so many different areas, like I mentioned in the bio, but system-wide EHR implementations. And then you've also done capital and project planning for new buildings of hospitals themselves. And then all the way to today, where you're leading digital health for Interior Health. And correct me if I'm wrong, but Interior Health, I believe, geographically is larger than the size of France, which is amazing because you have so many parts that you have to connect together. I'm really curious to start the conversation, like what got you into healthcare in the first place?
Yeah, it's a good question, and I've reflected on it a few times. It was a job. That's about it. It matched my skill set. The opportunity to it was a business analyst position supporting the recently formed Interior Health. Health authorities in British Columbia were formed in December of 2001. I joined summer of 2002. We were just figuring out a plan. How do we consolidate all our back office systems from what was these different regions into a single system? So I came in and assisted with that work. What's more interesting to explore, perhaps, is why I've stayed in healthcare. And, I have had a number of different roles within health. And I have to tell you, I'm fiercely proud of our Canadian healthcare system. There aren't too many other truly single-payer systems in the world. And that creates an incredible opportunity, but also an incredible challenge. And so while I'm proud of Canada's healthcare system, I also see that for the good and the bad, access challenges, wait times, things that we can do better on. And so that's what excites me about my job. That's what gets me out of bed in the morning, is the opportunity to take part, work towards making the single payer system sustainable, making sure it's actually there for future generations as well.
I love that, Brent. And I think, digital health can certainly play a role in helping to make healthcare accessible and safer for Canadians. And I'm guessing that's a big reason why you're so focused on leading digital. I'm curious, so you returned to Interior Health relatively recently to kind of lead digital health. When you get to a new organization like that and you have to get a lay of the land, how do you figure out like where you start? Because digital health is such a huge umbrella of so many things you could do. What was your initial, I guess, set of steps to figure things out and decide what to do first?
It's a good question. It's, I mean, there isn't a playbook I can point to. I like the 30, 60, 90-day approach to starting a new role, but really it's about, okay, it's just listening, it's engaging, it's getting out of the office here, going to some of our different hospitals and some of our rural and remote areas, talking to staff in those areas, talking to the digital health staff. What's going well? What could we be doing better? What are our priorities for the next 6 months? What are our priorities for the next 3 to 5 years? It's asking all those questions and listening. And then there's also listening to, my peers on the executive team here. Okay, clinical operations. Where are you guys struggling right now? What are your challenges? Finance. What's working? What's not working? Right? So it's just being willing to listen, to hear the good and the bad, and then act on it.
Yeah. And
I love
Brent,
that. Oh, sorry. Go ahead, Alan.
I was just going to say, Brent, you joined initially your career as a business analyst. You have an MBA, so definitely business minded. And then, of course, you've been responsible for EHR implementations and capital planning for different projects. How does that diverse background influence the approach that you take with digital health today?
Yeah, I think there's a couple things that are gonna stand and that we sort of default to, whether it's a rapid 6-week quality improvement project or a multi-year major system transformation. And there's a few things I draw on. One is just the discipline of execution, right? It is a discipline. And we can't have a single approach. There isn't a single project management or project delivery approach that's going to work in every scenario. So it's being adaptable and being focused on the outcomes established. And it's good governance as well. It's easy to say, it's really hard to do. Governance is challenging. And I will note that the larger the enterprise that you're driving the change in, the more complex the governance gets and the more critical it is to ensure success. As an example, I'm based in Kelowna. Some of the senior executive team is based in Kelowna for Interior Health. But as you noted off the top, it is a large geography. 21 acute care hospitals, right, scattered and ranging in size from, nearly 500 beds at Kelowna General to a handful of beds in some of our smaller rural remote facilities. If I'm looking to transform the entire system or particular function within our system across this entire region, I can't come up with the implementation plan and delivery approach that works at KGH and think that that's going to work at Golden District Hospital, right? Or that's going to work at Elk Valley Hospital or Princeton General with 2 beds, right? It's very different. And so being able to have that dynamic approach to project delivery is really critical.
Makes a ton of sense. Brent, if we look back even 5 years ago, a VP digital health role like yours was probably barely existed, but this role has really emerged in the last couple of years. What do you think makes digital health so much more important today than ever before that a role like yours just has to exist? Like, what's changed from your perspective?
Yeah, it has changed for sure. When I started in healthcare, the role of that CIO, the Chief Information Officer, I've seen the CIO reporting to the Vice President of Human Resources, and then through the executive team. I've seen the CIO report through like the Chief Operations Officer, and then to the senior executive team. And now what you're seeing is that CIO position sort of starts to get elevated, and now this idea of the VP of Digital Health. And I think it's a recognition that a lot of the challenges facing the healthcare system, like so many other industries, there are digital solutions to those challenges. And it's a recognition that whether it's the health human resource crunch, rural remote staffing challenges, connecting remote patients to specialist services, even finding improvements in the back office functioning of a large organization, there's now a recognition and appreciation that technology and information systems can go a long way to push the organization forward and to start actually connecting our patients, connecting our services, extending the reach of our caregivers, the reach of our clinical staff, and ultimately, sort of tying this back, improving the efficiency of the healthcare delivery right across Canada. So the shift is, he has gone from being an expense line, similar to a lot of other things that were just viewed as an expense line. Oh yeah, they got to keep those records intact. Oh yeah, they have to be stored securely. To being, hey, how can technology, how can innovation help us meet the challenges of today? And as I mentioned a few of them, responding to a global pandemic is another, right? Assisting with the rapid evacuation of 900 long-term care residents due to the threat of wildfire. It's another place where digital health can really help and assist with those type of operational demands and pressures.
So it went from a situation of, well, gosh, we have to use technology to digitize records or do basic things. Now it's an enabler for business transformation, it sounds like.
Absolutely. That's exactly what it is. And it is about digital transformation. It's about recognizing health takes a lot of criticism. Health takes a lot of criticism for being a laggard, for being slow to adopt technology and transform our business models. And, when I've given 20 plus years to technology and healthcare, that stings a little. I think that personally, but the reality is we're a risk-first enterprise. Everything we do has to be put up against the risk of potentially doing harm to our patients and ensuring our staff are kept safe in the provision of care. We cannot be negligent in recognizing the risks in the work that we do. So that is going to make us slower to adopt some of these technologies, but it's happening now, and it's happening through the consumer space. That's driving a lot of the change, which is fantastic. Healthcare in Canada and technology, I've seen it where we've seen the consumer advancements act as like a threat. Like, oh, no, that's, we need to be, the mandate of Interior Health is to meet all the health needs for the citizens of this part of British Columbia. Therefore, we really shouldn't be comfortable with our citizens using Apple Health or consumer tools to manage their health. It's just the opposite, though. Those consumer-based tools can help drive us forward, help inform our patients, right, when they're receiving care from us. So it's an exciting time.
I think you have a really good point about risk tolerance in healthcare. So when I think about if I go on the website of, my telco provider and, I want to ask a question about my bill or my service, I'm totally fine talking to a chatbot, an AI agent, because even if they get something wrong, what's the worst that could happen? I get the wrong bill or something. No one's going to get hurt from that. But in healthcare, if, a patient is chatting with a chatbot or an AI agent about something about their actual care delivery or their medications or something else, and you get that wrong, the downside risk can be incredibly high. And so to your point, we have to have a higher threshold for risk in healthcare because you deal with like literal patient lives. That's such a unique situation. I hope consumers realize like that safety has to be paramount. It's totally different than almost any other industry.
Yeah, and I look at the advancements of AI, and it's not a threat to our business model. Actually, it's an incredible opportunity to improve the quality of our care. This isn't about, oh, good, we can finally replace that high-priced specialist physician with a robot. That's not what the promise of AI in healthcare is. Not at this time, anyways. It's about having another support, another, call it set of eyes, if you will, another quality control indicator, something to just assist, not to take over. And I think if we're able to position it that way, through that lens, and not as a threat to jobs or employment, then we can start to realize some of those benefits.
It's a great point. And I can see a lot of, maybe frontline clinicians being worried about it being maybe a threat to their role in the healthcare system. And I agree with you that I think it's going to be more of an enabler, almost like an assist to clinicians. How do you navigate that with clinicians? Like, what sort of dialogue do you have? How do you engage them to make sure they're bought in? Like, what does that look like at the front line?
Yeah, I think it can't be Brent and his digital health team marching the solutions into the hospital, into the long-term care facility, into the community health center saying, here's what we're going to do from now on, right? It's got to be clinician-led. And so what I want to do with the digital health team is ensure they've got relationships with the providers, relationships with the clinical staff, with the administrative staff. And we're actually thinking, okay, what's the business problem we want to solve? And then what are the options that are out there for us? Rural remote in Interior Health is a significant challenge. Service disruptions are the reality. In a small community, I've seen it where one nurse or one physician, I can't make it to work today for a multitude of reasons, and we have to temporarily shutter a service. And that's a challenge for a small community. And so really keen and doing some really interesting work here around, how can digital health help to start bridge that divide when we don't have that care provider in person? What can we do to connect a remote provider or other staffing supports through virtual technology to ensure that that service stays viable for that community?
Yeah, absolutely. So Brent, you started your career at Interior Health and you moved over to Fraser Health to help implement their Meditech Expand system. And then you returned to IHA post-COVID. And I'm really curious, when you rejoined Interior Health, you wrote a post about the connection that you had to the Okanagan region and the people there. And we're talking about this idea of community. And I'm really curious, how does a sense of place and community impact your vision for enhancing digital health services for the people that you serve?
Yeah, let me tell you a little bit about that transition. First of all, it's tough to relocate a family with two teenagers in the midst of COVID and put roots down. That was an interesting time, that transition to Fraser. By the time my family was able to join, COVID was in place, and there wasn't a community to connect with. We were at home. It was the reality of the pandemic. It made it a challenge. But I had the privilege of attending a meeting, the Kwantlen Nation, the band offices, and we were sitting around the table and just taking time to meet everyone. And everyone gave a brief introduction and told their story. And I was really excited and taken aback at the same time as I listened to some of the elders and elected officials of the Kwantlen Nation talk about their connection to the Fraser Valley and the Fraser River that was right outside the doors there, and the history of the fishing and the land and the agriculture and the multitude of generations that were part of that same land. And I listened to that story and variants of that again and again. And as the table's coming towards me, I'm thinking, where are my roots, right? So, okay, on my mom's side, I have a Norwegian grandfather and I had an American grandmother. And on my dad's side, displaced Germans who lived in Poland on the, border with the Ukraine, and then moved to Canada as farmers. I thought, where are my deep roots? What is my background? Well, my heritage is white settler in Canada, and I thought about this question. And as I was mulling over that question, I was on vacation and I was in Kelowna, and I had an acquaintance say to me, your friends and family are here. When are you going to come back here? Right. And it was poignant, and it struck with me. And then soon after, I heard about the opportunity to come back. And so that's what really facilitated the move. It wasn't, it really wasn't work necessarily, although it's a fantastic opportunity here at Interior. But it really was about connection to family and background. However small that background might be, or however limited that time might be. And so that's a little bit about the journey of how I came back. What I can say is Interior Health's done a really great job at retaining a lot of their employment. And there's probably a few reasons for that, but there's a lot of long-standing employees. And when I look at our exit rates, the majority of exits are retirement rather than people leaving for other employment opportunities, which means that there's a lot of seasoned professionals in this organization with lots of years experience. And that certainly makes my transition a lot easier. So what can I do? Well, I try to just take advantage of that knowledge that exists in the workforce here and those years of experience.
That's amazing. And there's something in the culture at Interior, it sounds like, that leads to such great retention. And, it's been particularly hard the last couple of years. We know lots of folks in healthcare have had the toughest time. People are leaving healthcare more than they used to because of, all the burnout and the challenges. I'm curious, as a leader in a large healthcare organization, how do you think about retention right now? How do you think about building a culture that gets people to stay when there's so many forces trying to get people to leave right now?
Yeah, it's a challenge. It's something as a leadership team we spend a lot of time discussing. It touches on a lot of leadership philosophies as well. And I'll just share that I've seen in health, and I've seen in other industries as well, where the leader feels that they need to be the smartest person in the room, or that by being in that leadership position, it's implied that they have to make the final decision. They have to synthesize the information. They have to be the default decision maker, regardless of what the scenario is. And I don't really subscribe to that idea of leadership. I'm the first to acknowledge I am not the smartest person in the room. That is not my role. My job, what I consider like objective number one, is to bring on the best and brightest people around me, people that are able to make complex decisions, which they are in healthcare. There aren't too many simple decisions, but make the complex decisions and drive digital transformation forward. To that end, how do we retain staff? How do we grow the team? Set people up to be, whether they're working in a team or as an individual, have the ability to make decisions. Try to give them as much autonomy as they can. Really enable their ability to find their own satisfaction in the work, right? As a leader, what I want to do is clear barriers. I want to clear runway, so to speak, and let them land the plane, if that analogy holds.
I love that. So giving people autonomy along with that purpose, so that way they're able to be leaders as well in different ways in the organization. That's awesome. Also, probably other ones where it's easy to say, hard to do, but
yeah,
that's so
definitely
critical.
I mean, it helps. Interior Health also has it's a beautiful part of British Columbia, from the Okanagan Valley wine country to the rugged mountains of the Kootenays and some of the beautiful plains and prairies in the Caribou and the amazing lakes up there. Once people are here, it is tough to leave.
On that note, Brent, BC is known for the landscapes and the beautiful wilderness and everything. I'm really curious, from a healthcare perspective, what would you say is unique about BC healthcare compared to other provinces in Canada? And maybe how do those differences shape how you think about delivering digital health in BC?
The first thing that comes to mind is the mandate. So the health authorities within BC really have a full health continuum mandate. So whether it's public health, health promotion, environmental health, of course, acute care, community care, long-term care, that's all packed within the mandate of the health authorities. And so that may not be completely unique in Canada. It was at the time the health authorities were formed. Now, we've seen other provinces go even bigger on mandates. Some stay smaller, more regional, and I'm thinking specifically of our neighbors in Alberta, went broad mandate, and now there's discussion maybe that won't hold. And then Ontario, where you see much more regionalized approach to care. In BC, that broad mandate is really an opportunity, and it's something we need to consider. So I'll just pick a problem of the day. It's our alternate level of care patients in our hospitals. So these are patients who are maybe in a medicine bed that don't require all the services of a normal medicine patient. They might be better, but there could be many reasons why we're not able to discharge that patient. Could be setting up some social supports or family supports in the community. They may be a homeless individual. It could also be that they're waiting space in a long-term care facility, or we're trying to get some community rehab or community nursing supports into their home. And those things can take time. Well, Interior Health has this mandate that includes all of those health services. So we should be, as a province, more able to manage that alternate level of care population in our hospitals, given that we have control of those other service points that are dependent, that the patient is dependent on. Now, that hasn't necessarily in all cases proven out. Our ALC rates are not great in British Columbia. There's some leaders and some not doing as well. And the challenges are very sometimes unique to a community. But it's that opportunity to span the continuum of care with digital solutions. I can't look at digital solutions specifically for the hospital. We have the privilege and the ability to look at digital solutions right across the continuum. So that's a really big opportunity. And it also is a challenge at the same time. Your number of interested parties increases. The number of complexities around governance that I touched on earlier are also present in that scenario. Back in the 80s, we were sharing stories, and I heard from a former colleague who said there was an IT shop of 3 working at Kelowna General Hospital, and there was no IT shop at Kelowna Community Health Services. Now, those two operations were distinct, not under a single organizational umbrella, but they met and they said, how can we help each other? And the community health services group said, gosh, we send our nurses out, we send our home support staff out, and we will find that there's no answer at the door. And we're immediately concerned. We're wanting to do wellness checks. We're contacting RCMP. We're not sure. Has someone fallen? There's a chance they've been admitted to the hospital. If you could just get us a list of yesterday's admits to the hospital, we can cross-reference with our active clients, and we will know not to send our home care nurse, our home support aide, other clinician out to that home. That simple business requirement was met through a printer install in a health center and a Meditech report being fired over to that printer on a nightly basis. No information sharing agreement in place, right? Probably should have been given the different agencies involved, but that was, mid to late 80s. And so that was the approach. Let's find a solution. Those aren't issues we're dealing with in our health system today. And so that I actually like the structure of the health authorities. I think it's reasonable. Perhaps some would say they're too large in mandate. Some would say, no, it should be bigger. There should just be one health authority for the province. I think that pendulum can swing back and forth. I don't think there is a perfect answer, but the key is to maximize the mandate and the ability to drive change with what your responsibility is. And that's what we're really focused on.
One of the fascinating things that's come to mind is, where I think we're continuing to see in different provinces, like amalgamation of regions. I think in Newfoundland, they just kind of amalgamated to a single Newfoundland health system. I haven't yet seen recently of any of these organizations split up and said, actually, we're going to swing the other way. And it's too large. We have to break things up. I don't think that's happened very much yet recently, but who knows? To your point, it may swing back the other way. And I think we can both see pros and cons of, if you're larger, you can standardize and have, like you said, manage the whole continuum of care. If you're smaller, maybe you can be more nimble and move faster and try things. Definitely pros and cons for each. One of the things that you've said in the past in terms of advice is fail, discover, succeed, learn, grow, and then repeat. That seems like a key philosophy for you. Kind of curious if there's a certain instance that comes to mind of how that approach has really been critical from driving innovation or technology in healthcare for you.
Yeah, I think it's Brent's take on plan, do, study, act, right? It really is that simple. And one of the things in healthcare in Canada, I sometimes get a little bit frustrated when there's a project failure or a data breach, something of significance. In healthcare, we need to recognize, again, single payer system. Let's share that. Let's share those experiences and be quick to share, just as quick as we are to want to publish our successes, because there's learning that can actually benefit all of our health systems, all of our different provincial jurisdictions and structures. And we can, by being more transparent when we fail, we can help prevent subsequent failures. Perhaps failures we can allow other jurisdictions to course correct and perhaps be more successful. So I strongly believe in that. And I look forward to the next conference where there's a failure track, educational track. What went wrong? Let's be transparent. Let's talk about it. It takes some humility to actually stand in front of your peers and say what didn't go right. But I just feel like the learnings are just as impactful and beneficial there as they are on the successful track. And for a specific example, I'll touch on my time at Fraser Health. We were launching a virtual hospital for psychiatry patients and trying to, again, extend our what was, limited inpatient psychiatry beds and find a way and a care model that could allow psychiatry patients to receive the clinical interventions they needed in the environment that they were day to day. And as opposed to the safe, controlled acute care environment where there aren't necessarily the same triggers and challenges that the patient's facing in their day to day. So we really saw a neat opportunity there. Well, my team was looking at the technology footprint. What's going to be needed to support the psychiatrists? What's going to be needed to support the nurses to ensure the patient was safe and had connection to the care providers? And we picked a technology that was available at the time. It was a home monitoring kit, and we procured a whole bunch and had them ready to go. We were gonna go aggressive in this space. And we realized we missed a key piece of functionality, and that was the ability for the patient to connect ad hoc back to the health system. We didn't want to put them through a phone tree. We wanted them to have the ability to, through video conferencing, to be able to see the face and hear the voice of a provider, essentially on demand. Think of a call bell in a hospital bed. We wanted that same feature, but from their home. The kits we had procured and were ready to deploy didn't meet that need. So we thought, okay, well, we'll get a bunch of secure tablets. We'll put a nice video conference interface on it, one touch. It'll be pre-programmed, great one call destination. It'll be easy, foolproof to use, and we'll deploy those with home health kits. And then pretty soon you looked at the form factor of what we're asking these patients who, again, are in a crisis scenario. We're asking them to take multiple devices and different peripherals and connect it all at home and then start to receive the care. And it was overkill. And so we said, you know what, this is wrong. Let's step back, bring a patient representative into the room. Let's talk about this. What is realistic? What is most important for the patient? In the end, it was really just that video call feature. That's what mattered. So that's what we ended up deploying, was just that single tablet. So just one example where, we had unfortunately procured a bunch of these other devices that weren't going to be needed anymore, but you have to be willing to reassess and not get locked in on what that solution is, right?
I love it. It's like it's water under the bridge. You can't get obsessed with the problem, but don't get obsessed with the first solution you had in mind. It makes
Exactly.
a lot of sense. And well, thank you for leading with that story of failure, because I think your idea of having a failure track at these large healthcare IT and digital conferences would be phenomenal. No one's done that yet. That's a great idea. Because I think to your point, Brett, whenever we go to those, sounds like everything's working.
Yeah, it sounds like we've got the most advanced health system in the world, right? I mean, it's nothing but successes everywhere you turn. It's not the reality.
Absolutely. And I think to your point, it takes leadership and folks like, you know what, I'm going to put my hand up and talk about what didn't work. Because until some folks start doing that and normalize discussing failure. And I think to your point, Brad, I think oftentimes we don't like to admit something didn't work and turn it off. But actually, if we can turn off stuff that's not working, like that's a win too, right? Imagine all these implementations you have where it's not working and people just keep them running and taking up time and resources because no one wants to admit, hey, I think we got this one wrong.
Yeah, absolutely.
Brent, another thing I wanted to chat with you about, you brought up earlier in the conversation this idea of empowering staff and fostering a sense of community amongst the people and the patients in the community. And there's this idea of the patient being part of the care team, and that's really gaining traction today, the past 5-10 years. I'm curious, how do you envision digital health technologies facilitating a stronger patient-provider partnership and improving overall health outcomes?
Yeah, it's interesting. I thought, wouldn't it be neat if our clinical information systems in our hospital were actually empty of patient data, and that only when a patient came and encountered our services would their chart and their data be exposed into the system. So think of the patient holding the master file of their health data, and it just being rendered then for care providers in the moment of providing care. And what if it led with the goals of care for the patient? What does this patient actually want? What does good living, positive life mean for the patient? So a patient going into Emerge might have a goal of care of comfort management, of pain management. They might be at end of life, palliative. And what we don't want in that scenario is to put a multitude of interventions into that patient and try to get them perhaps to a place that they're not wanting to be. And I have a personal story where, my grandmother had a meeting with her family physician, and my grandfather and my mom was there, and they talked about a cancer diagnosis that was just given to my grandmother. And it was pretty serious. It wasn't the first cancer diagnosis, but my grandmother, she wanted to she felt like cancer wasn't a match for her and that she could have a very, very good life in spite of that cancer. And she'd be willing to take any interventions recommended to battle that cancer diagnosis. But she ended the discussion by saying, if I were to have another major illness or something where I lost functional use of arms or legs, I wouldn't have the energy to fight cancer. So as an example, if she had a stroke, she wouldn't want to then battle cancer. And 2 days later, she had a massive stroke. And my grandfather, of course, I would do the same, panicked, get you to emerge and start the interventions. And it wasn't until the family physician came, and then my mom was able to get there and said, no, let's withdraw these interventions. Her goals of care were clearly articulated. And that was a challenging situation, but we were able to ensure that the patient's wishes were met. I think about the conversations that happen in the primary care space that unfortunately are still isolated today or siloed from the interventions that are often carried out in the acute care space. And one of the goals I see and one of the promises of patient at the center of system design is that we can start to bridge those gaps. And there's an interoperability challenge in BC. There's a health legislation challenge, but I feel like if we put the patient at the center of design for these systems, it's going to start with those things, those conversations that are so critically important that happen outside of the emergency department, outside of the acute care hospital. Our systems, by and large, today have been provider-centric, provider-designed, and that's not a criticism. That's completely understandable. It's the providers that are using that system. But if we can bring in that patient voice a little bit more loud and a little bit more to what's going to matter there, then I think our system design is going to continue to evolve, and we're going to start to see more self-serve, just more ability for the patient to actually contribute to that health chart rather than just the registered professionals.
I love that. It's like bringing the humanity back to healthcare. So, Brent, just being mindful of your time, let's flip over to the Fast 5 lightning round. Just 5 quick questions to get to know you better for our audience. The first question we have is, what is your favorite book or book you gifted the most?
Book I've gifted the most is One Good Story, that one by Thomas King, a collection of short stories by Thomas King, and they're funny, they're poignant, and just an excellent read.
Awesome. Question 2, who is a person either dead or alive you'd love to meet?
Leonard Cohen, just my favorite poet turned musician turned poet. I never had the chance to see Leonard perform when he was around, and I'd love to go for coffee with him.
Yeah, awesome. Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
Oh, none of the above, just trying to get comfortable in my own skin.
Love it. Question 4, what is something in healthcare you believe that others might find insane?
Well, I don't think the public really understands that if you have an MR or a CT at a private imaging clinic, there's a good chance when you're in need of acute care at a hospital that they don't have access to that image. Mm-hmm. That's not universally the case across Canada, but our patients are often duplicate imaged simply because the information sharing agreements and the technology isn't permitting those images to be shared, and that just shouldn't happen.
Yeah, totally. That's a whole other podcast episode right there. Question 5, the last question we have, if you could travel back in time to any event or moment, what would it be and why?
Oh, it would be the dawn of time, Inception. I could write the definitive book on how this great comedy got started.
That's awesome. That's amazing. I love that answer. Well, thank you, Brent. That's a wrap for this episode of The Digital Patient, hosted by SeamlessMD. You can follow us on Twitter at SeamlessMD. And if you like the podcast, you want to learn more, visit www.seamless.md. Brent, again, thank you so much for spending some time with us and bringing all the wisdom that you've brought to the conversation today.
Yeah, thanks for having me both. Really appreciated the time.